Good evening, respected dignitaries, honorable teachers, doctors, PG scholars, interns, and all the homeopathic lovers joining us from the different parts of the India across the globe. A very warm welcome to the 2001 day of the uninterrupted daily webinar series of the International Forum for Promoting Homeopathy, IFPH. I am Dr. Rinkal Advaryu, and it's my privilege to be your moderators for today's enlightening academic session. Today's topic is a homeopathic view in hypersensitive reaction type 1 with case presentation. The session will help us to understand how classical homeopathic principles can be applied in managing type 1 hypersensitivity disorders through a well documented clinical case. Before we begin, I request to everyone to kindly keep your microphones on mute throughout the session and actively participate through the chat box for questions and discussions. Now, I will introduce the speaker. It is now my pleasure to introduce our esteemed speaker. We are honored to have Dr. Abhishek Rana, an MD scholar from the Department of Homeopathic Case Taking and Repertory. Dr. Abhishek has a keen interest in case analysis, repertorization, and evidence based homeopathic practice. Today, he will share his valuable clinical experience and insights on a homeopathic management of type 1 hypersensitivity reaction through an interesting case presentation. Sir, on behalf of the entire IFPH family, we extend a heartfelt welcome. We are eager to learn from your expertise. Over to you, Dr. Abhishek.
Good evening, everyone. Respected moderators, distinguished faculty member, esteemed doctor, researchers, dear students, and all the participants joining us from the different parts of the world. A very warm welcome to each one of you. First and foremost, I would like to express my heartfelt gratitude to the International Forum for Promoting Homeopathy, IFPH, for providing me this wonderful opportunity to present on an important clinically relevant topic. I am Dr. Abhishek Rana, MD Scholar, Department of Homeopathic Case Taking and Repertory from Rajkot Homeopathic Medical College. Today, I will be speaking on the homeopathic view in type 1 hypersensitive reaction with case presentation. First of all, I will share my screen. Screen is visible or not?
Yes, visible.
Okay, thank you, sir. Today, my topic was homeopathic view in hypersensitivity reaction type 1 with case presentation. First, briefly, I introduce how many or which are the topics which we cover today. First, we discuss what is hypersensitivity, different type of hypersensitivity, and the detail in each disease of the type 1 hypersensitivity in relation with idiosyncrasy and with the therapeutic drugs which are used in those cases, and also the case presentation. Let's we start. There is a hypersensitivity reaction when the defense become the disease. Okay. The first of all, the definition we all know: the injurious immune reaction called hypersensitivity are the basis of the pathology associated with the immunological disease. Hypersensitivity implies an excessive or harmful reaction to an antigen. It is occur when the normal defense mechanisms are poorly controlled, excessive, or misdirected against the harmless entities. Here we see there is a balance. The left side there is a control mechanism, and the right side there is effector mechanism. When there is a balance which our body cannot maintain, then that type of disease can occur. Next, the trigger factor, root of the disease. First of all, we discuss the triggers. There is a two type mainly, the exogenous antigen and endogenous antigen. First, there is an exogenous antigen. In this, there is a virus, bacteria, parasite, any substance like a pollen grains or etc. Or any food material can be that, and the drugs. And There is a range from travel, itching, and fatal anaphylaxis that can cause. The second one, endogenous antigen, that are the part of our body which can work as a antigen. Immune response against the autologous self-antigen result in autoimmune disease. And then the susceptibility, which are the people who are susceptible to develop that type of disease. First, genetic. Most common there is a HLA gene and non-HLA gene. First, the HLA was under the genetics, and in non-HLA gene there is an environmental factor. Early exposure to environment, antigen, and microbe educate the immune system, prevent allergen and autoimmune reaction. There are the four type of hypersensitivity. The first was immediate. It also we can call it the false alarm. The second one was the antibody mediated. Like mistaken identity. The third one, immune complex, the collateral damage. And type 4, that are the cell mediated, or also called the delayed type of hypersensitivity reaction. First, we discuss the type 1 in detail. Also known as immediate type of hypersensitivity reaction, and also the false alarm. A rapid immunological reaction occurring in the previously sensitized individual triggered by the binding of an antigen to IgE antibodies on the surface of the mast cell. As we see in the figure, there is an allergen. It can be any allergen, pollen grains, any other substance which we are sensitive. And there is bind with the cross-link IgE, which are the present on the mast cell. There is a highly affiliated FCERI, which are attached with the IgE, and then pollen grain are attached, then can perform a mediator like histamine and protease can release and then further develop the pathology. Now we will see in the detail the etiopathogenesis and the different step or stages of this. First, the sensitized balance, the genetic versus environment. In genetic type, the definition, the increased propensity to develop immediate hypersensitivity due to high serum IgE, more interleukin-4 production, a T helper cell, 2 cell, an inherited positive family history found in 50% of atopic individual. The key feature is there is a release of enzyme of cytokine like interleukin 3, interleukin 4, interleukin 5, 9, and interleukin 30, and etc. In environment, we see previously hygiene and hypothesis. The decreased early childhood prenatal microbial exposure, which prevent the education of the immune system, leading to allergies later in life, like pollutant and virus. Industrial environment, pollutant and viral airway infection strongly trigger the asthma. There is an example. Non-atopic allergy. 20 to 30% of the immediate hypersensitivity triggered by the non-antigenic stimuli. Temperature, extreme exercise without a T helper cell IgE involvement. In this first type, there is a antigen was free and antibody was fixed. Now we first see first phase of etiopathogenesis, the silent phase, arming the mast cell. Step 1, there is an antigen presentation. When any antigen which come from outside, which attach with the dendritic cell, or then captured by the environmental allergen at the site of entry and present it to a CD4 plus T cell. In second step, T helper cell type 2 differentiated directed by the local cytokine interleukin 4 and T cell differentiated into the T helper cell 2. In step 3, cytokine secretion, which can secrete by interleukin 4, which can stimulate the beta cell, and interleukin 5, which activate the eosinophil, in interleukin 30, which can enhance the IgE production and stimulate the epithelial mucosal secretion. In step 4, the class switching interleukin 4 act on the beta cell and triggering the class switching to produce the IgE antibodies specific to the allergen. In step 5, sensitization. After that sensitization phase, the IgE bind with the highly affinity FCERI receptor which are presented on the mast cell, and then person has developed the type 1 hypersensitivity to certain substances. And now the system is now armed and waiting for the allergen. And there is, we can see the figure, the trigger of the IgE cross-link. The first one was there is no activation. The monomeric allergen bind to a single IgE, no internal signals. Activation ways, the multivalent allergen bind to adjacent IgEs, physically pulling FCER receptor together. And then the mechanism, the activation require a multivalent antigen to physically cross-link adjacent IgE antibody. The consequence, the physical proximity of the underlying FCRI receptor activate the cytoplasmic signal transduction. The output, the signal trigger immediate explosive degranulation and subsequent late phase mediator synthesis. Here we can see the diagram. First of all, there is an antigen come and bind on the IgE receptor, and then IgE Fc receptor, which can signal for the degranulation that can release the granular content like histamine and proteases. In second, there is a membrane phospholipid, which can secrete the arachidonic acid and platelet activating factor. And then arachidonic acid, which can secrete the prostaglandin D2 and leukotrienes D4, C4, and D4. The histamine and then prostaglandin and leukotriene, which are immediate response and can done the vasodilatation, vascular leakage, and smooth muscle spasm, which are the responsible for the development of the symptoms in hypersensitivity type 1. And in third signal, the signal for the cytokine gene activation. There is a secretion cytokine and the chemokinin in late phase reaction, the leukocyte infiltration, epithelial damage, and bronchospasm. Here there is the same thing. Three zones are there. First zone, there is cytoplasmic granule immediate release. Zone 2, membrane phospholipids de novo synthesis. And zone 3, nucleus transcription and secretion. There is a pro-filling the mediators. The mediator arsenals. Preformed mediators granules is a vasoactive amines, histamine, which can cause intense smooth muscle contraction, increase vascular permeability, mucus secretion. Enzyme like chymase, trypsis, and acid hydrolase cause the tissue damage, generate kinin activity complement. And the proteogenic glycan, heparin, chondroitic sulfate, which package and store amines into granules. In second zone, the lipid mediator membrane derive arachidonic acid. They secrete the leukotriene C4D4, spasmogenic vasoactive agent, 1,000 of times more potent than histamine for vascular permeability and bronchial contraction. And leukotriene B4, which is highly chemotactic for neutrophil, which can may send the signal, and more neutrophil and eosinophil monocyte can come on the site of where the antigen was come. Prostaglandin D2, most abundant COX pathway, mediator cause intense bronchospasm and mucus secretion. Platelet activating factor, platelet aggregation, vasodilatation, and bronchospasm. And in the third last, cytokine secretes. There can tumor necrosis factor, interleukin 1, chemokinase promote the leukocyte recruitment in late phase. For interleukin 4, amplifies the ongoing T helper cell 2 response. Type 1, the biphasic mechanism. First, there is immediate reaction at 0 to 2 hour. Mechanism, the mast cell degranulation, histamine and lipid mediators. And there is a clinical symptom, there is a clinical effects. There is a vasodilatation, vascular leakage, smooth muscle spasm. In late phase, there is occur in from 2 to 24 hours. Mechanism, cytokine recruit leukocyte, eosinophil, and neutrophils. Clinical effect, there is a leukocyte infiltration, epithelial damage, sustained inflammation. There is the eosinophilic wrecking ball. Recruitment. Eosinophil are summoned to the site of the immediate hypersensitivity by chemokinin like eotaxin activation. The T helper cell 2 cytokine interleukin 5 is the most potent and eosinophilic activating cytokine known. The direct damage upon the activation, eosinophil liberate in a proteolytic enzyme into unique protein that direct the damage mucosal epithelial tissue and major basic protein, eosinophilic cationic protein. The result, the late phase reaction, is major cause of the symptom in the chronic type 1 disorder, such as allergic asthma, derived by the cellular destruction rather than the just passive fluid leakage. Here we see there is a type 1, the clinical spectrum, the local 10 to 20% of population. Generally seen, we have the type 1 hypersensitive reaction. First of all, there is a allergic rhinitis, there is an increased mucosal discharge. In bronchial asthma, there is airway obstruction due to the hypersecretion in our airway. In food allergy, there is increased peristalsis movement with complaint of diarrhea, watery stool, etc. In urticaria, there is hive presence. There is a local effect, and there is a, if they can continue, then systematic or critical alert. There is a trigger factor. There is a foreign protein, penicillin, bean venom, peanuts. Manifestation like for the systemic or critical alert, there is a vascular shock, plummeting blood pressure, widespread edema, laryngeal airway obstruction. For laryngeal airway obstruction, we also seen in angioedema as a complication. And the last one, is anaphylactic shock. Now, for type 1 was complete, and further we detail see the disease which are the seen in type 1 hypersensitive reaction. Now, this is type 2 hypersensitivity reaction antibody mediated. The mistake in identity. Antibody IgG and IgM react with the antigen present directly on the target cell surface or in the extracellular matrix, causing the disease by destroying the cell and triggering the inflammation or interfering with the normal function. Here we can see there is IgG and IgM autoantibody, normal tissue antigen, and normal tissue anti-cell. In this type, there is a antigen was a free and antibody. Sorry, there's a mistake. Antibody was free and antigen was fixed. Here we see the example of the type 2 hypersensitivity reaction, three mechanism of injury. First, there is a opsonization and phagocytosis. There is a we seen in the autoimmune hemolytic anemia. The macrophages engulf the RBC. The marked cell is ingested by the phagocytes. There is an example of autoimmune hemolytic anemia. The second one was the complement-mediated inflammation. The autobodies deposit in fixed tissue, recruiting the leukocyte and damaging the tissue. For example, there is a Goodpasture syndrome. Goodpasture syndrome was also autoimmune disorder in that there is a sensitivity towards the type 3 collagen, which are present in the lung membrane or glomerular filtration in kidney, which can destruct, and we patient have complaint of hematuria or hemoptysis. And the third variety was cellular dysfunction. And there we seen in the myasthenia gravis, which generally have patient come with a weakness. There is antibody inhibit binding on the neurotransmitter to receptor. Here we see there is acetylcholine, which are secreted by the motor neurons, but in that cases, the IgM, IgG antibodies bind with this receptor and can produce the myasthenia gravis. And the last one, there is a grave disease which causes the hyperthyroidism. Antibody impair or dysregulate the cell function without causing a cell injury or inflammation. There is a type 3 immune complex mediated or also known as collateral damage. The antigen antibody IgG and IgM complexes form freely in the blood. Tissue damage occur because this complex is deposited in vessel, eliciting massive inflammation at the site of deposition. Here you can see in that type, the antigen and antibody both are free. The circulating antigen and antibody complexes are there. The problem is not the target, but the deposition. Type 3, the three phases of the pathology. First one was formation, a week post of exposure. Introduction of antigen triggers antibody production. Free antibodies bind to the circulatory antigen, creating a large complexes. And the second phase was the deposition. The complexes is lodged in tissue where the blood is filtered at the high pressure. Example: kidney, glomeruli, joint, small blood vessels, medium-sized complexes. Slight antigen excess are the most pathogenic. And the third and the last phase, the inflammation and tissue injury. Approximately 10 days of post-exposure. There is a deposited complexes activate the complement and recruit neutrophils. A lysosomal enzyme are released and causing the intense vessel necrosis, fibrinoid necrosis, and vasculitis. And the last one is type 4, cell-mediated, the delayed type of hypersensitivity reaction. There is no antibody antigen. There is due to the activation of T cell, T lymphocyte. The cell-mediated type of hypersensitivity is caused by the inflammation resulting from cytokine produced by the CD4 T cell and the cell killing by the CD4 T cell. There is no antibody involvement. There is involvement of the T cell. The delayed type of hypersensitivity, because this response relies on the physical mobilization, proliferation, and travel of the cellular infantry. Rather than the preformed circulating antibody, the reaction take 24 to 48 hours to reach its peak. That's why we also call the delay type of hypersensitivity reaction. Type 4, CD4 plus CD8 pathway. CD4 plus cytokine mediated inflammation. T cells secrete the cytokine that recruit and chronically activate the macrophages and the neutrophils. Example, in case of multiple sclerosis or rheumatoid arthritis. CD4 T cell mediated cytotoxicity. CTLS directly recognize antigen on the target cell and inject the lethal protein to induce apoptosis. Example, there is a type 1 diabetes. A type 4 clinically hallmark. The granulomatous inflammation and contact dermatitis, both are the example of the type 4 hypersensitivity reaction. In granulomatous inflammation arises from the persistent non-degranulous antigen like tuberculosis. Activated macrophages morph into epithelioid cell to structurally wall off the threat. In contact dermatitis, environmental chemically urushiol structurally modify a cell protein, making them appear foreign to T cell, result in epidermal necrosis and blistering in 24 to 48 hours after the contact. Here there is a chart of the four type of, and we revise that. The hypersensitivity diagnostic matrix. First, there's a type 1, immediate type 1, there's a primary immune mechanism was IgE and mast cell. The core pathological process was degranulation, histamine release, and the late phase inflammation. And the disease are the asthma, allergic rhinitis, and in complicated cases, there's anaphylactic reaction. A type 2 antibody mediated. There is a primary immune mechanism due to the IgG and IgM autoantibodies. The core pathological process was opsonization and phagocytosis, complement activation, receptor dysfunction. Disorder are the autoimmune hemolytic anemia, Graves' disease, myasthenia gravis, and Goodpasture syndrome. Type 3, immune complex. The primary immune mechanism was the antigen-antibody complexes. The core pathological process was the tissue deposition, complement activation, fibrinoid necrosis, and vasculitis. And the example are the systemic lupus erythematosus and serum sickness. In type 4, a cell-mediated hypersensitivity. Primary immune mechanism is due to the CD4 plus and the CD8 plus T cell. This is a core pathological process of cytokine-mediated macrophage activation and direct target cell lysis. And the prototype disorders are the contact dermatitis, multiple sclerosis, and type 1 diabetes. Here, now we see the disease which are under the type 1 hypersensitive reaction. There is a localized and systemic, both are there. Allergic rhinitis, example are the allergic rhinitis, urticaria, angioedema, and anaphylaxis. First, there is sensitization. There are the three phases of type 1 hypersensitive reaction. Also, we discussed previously. First one, sensitization. Allergen-specific IgE bind to the highly affinity XER receptor composed to 1 alpha and 1 beta and 2 gamma chain on resting mast cell and the basophil. Activation. Polymeric antigen cross-link to sensitize the tetrameric receptor. This initiates signal transduction via lean and sky tyrosine kinase, leading to a massive intracellular calcium influx. Hello. Hello.
Yes.
Am I audible, sir?
Yes, everything's fine. You are doing well.
Okay, sir.
Go ahead.
My screen is visible, sir.
Everything fine. This is absolutely fine.
I got message, so that's why I asked. Okay, sir. Continue here. Second, there is activation. Polymeric antigen cross-link the sensitized tetrameric receptor. This initiates the signal transduction via lean and sync tyrosine kinase, leading to a massive intracellular calcium influx. Third, degranulation. Calcium-dependent activity on the phospholipase facilitates the fusion of a secretory granules with the plasma lemma, releasing bioactive production while maintaining the viability. Wave 3, cytokine chemokinin agent like tumor necrosis factor alpha, interleukin 4, interleukin 5, interleukin 30. Effect, the upregulate the IgE production, sustaining late phase T helper cell type 2 inflammation and the derived cellular infiltration, eosinophil and basophilic. There is a time 6 to 8 hour in post-exo exposure. In wave 4, the lipid mediator agent like prostaglandin D2 and cystinyl leukotriene LTC4, LTD4, LTE4, platelet activating factor, and the effect is the most potent known, the bronchoconstriction, induced vascular leak, LTB4 mediated neutrophil and eosinophilic chemotaxis. The last one, cytokine and chemokinase. Agent was the tumor necrosis factor, same as above, interleukin 4, interleukin 5, interleukin 30. Effect, upregulates the IgE production, sustain late phase T helper cell 2 inflammation and derive cellular infiltration, eosinophils and basophils, 6 to 8 hours of the post-exposure. Now, we discuss the disease condition, the allergic rhinitis, our definition. You all know that the inflammation of the nasal passage occurring in the temporal relationship to allergen exposure, classified as a seasonal or perennial. Etiological, the causes, airborne pollution, in May, grasses, weed, ragweed, perennial, animal dander, dust mite, cockroach-derived protein, and mold spore. Predisposing factor, atopic background, asthma, atopic dermatitis, food allergy, more common in female sex, exposure to particulate air pollution or maternal tobacco smoking. Peak prevalence more than 30% occur in the 5th decade of life. Now there is a pathophysiological feature and clinical feature. In pathology, we already discussed the allergen impingement in the mucosal blanket, IgE mast cell, degranulation and tissue edema, eosinophilic infiltration. Ensign symptom, episodic rhinorrhea, paroxysmal sneezing, nasal obstruction, mucus pruritus, conjunctivitis, nasal mucosa, and oropharynx. In complication, there is anosmia if nasal polyp form, secondary sinus, middle ear infection. In investigation, we can done the serum IgE level, also count the eosinophil in the CBC or skin prick test. Treatment in allied part, there is a antihistamine. Nothing is there. There is urticaria and angioedema. We can differentiate it with this figure. In urticaria, there is involvement of the epidermis, more prominent, superficial skin layer. In angioedema, there is a deep dermis and subcutaneous tissue. Urticaria, the definition, superficial dermal vascular dilatation, pathophysiological, localized mast cell histamine release, causing superficial venular permeability. In clinical feature, there is a well circumscribed wheels with the erythematous raised serpiginous border and the balanced center. Key feature, intensely pruritus or itchy. appear in the crops. Individual lesion last more than 36, less than 36 hours in acute cases, or more than 6 weeks in chronic cases. Causes and predisposing factor. Female are more predominant. Atopic history. Peak in third and fifth decades. Causes: acute food, drug, viral infection. In chronic, there is idiopathic. In physical dermographism, liner wheel with stroking, cold, heat, and pressure. Now there is angioedema, the deep tissue swelling, frequently GI colic cramping, risk of fatal laryngeal edema. This is the pathophysiology, mast cell variant. The pathology, IgE mediated, often accompanying urticaria. Feature may have some pruritus if concurrent with urticaria. Causes are say food, drug, or insect sting. The bradykinin, excessive pathophysiological, excessive bradykinin generation in feature conspicuous or non-pruritic, absolute absence of urticaria. Symptom last more than 24 hours. Causes: acetylcholine inhibitor, impair bradykinin degradation, or hereditary acquired C1 inhibitory C1 INH deficiency. Predisposing factor: break race, orange transplant, female gender, smoking, or increased age. There is investigation and the protocol, mostly clinical history. If chronic and painful more than 36 hours, biopsy to rule out the urticaria vasculitis. If isolated angioedema, check complement level of C4, C2, C1, INH for suspected hereditary angioedema. Treatment: there is antihistamine, H2 antagonist, also the CYS-LT leukotriene antagonist, or steroid, or monoclonal anti-IgE for refractory cases. Treatment for the bradykinin mediated hereditary angioedema, acute intervention, recombinant C1 INH protein fusion, bradykinin 2 antagonist, and kallikrein inhibitor, fresh frozen plasma. The last one, there is anaphylaxis, potentially life-threatening systemic allergic reaction involving one or more organ systemic, typically occurring with the second to a minute of exposure to the trigger. Predisposing factor: there is a history of asthma, underlying cardiovascular disease, atopic history, occupation. Primary cause: there is the most common we seen in penicillin previously. Now there is not so much common. Or food, peanuts, tree nuts, alpha gal, and etc. The systemic pathology: there is a massive release of histamine, cysteine, leukotriene, PGD2, PF lead to profound vasodilatation, microvascular permeability, and smooth muscle spasm. Here, cardiovascular: there is a hypotension, vascular collapse, tachycardia, loss of intravenous fluid. In GI tract, there is a nausea, vomiting, cramp in abdomen, fecal incontinence. In respiratory, there is a hypoxia, fatal laryngeal edema, and bronchospasm. In the cutaneous, more than 90% of cases, diffuse urticaria, flushing, generalized warmth. Now, phase 1, acute crisis management. Investigation: primarily clinical diagnosis based on history and rapid symptom onset, acute serum histamine for a reaction. Immediate treatment: immediate self-administration of epinephrine, absolute imperative. Phase 2, long-term prevention and modification. Avoidance: strict avoidance of the unknown trigger. A specific immunotherapy, subcutaneous escalating dose of venom for hymenopterin 3 to 5 or to lifelong. Tolerance induced: the LEP study provoked early introduction of peanut protein to high-risk infant, which prevent 80% of the peanut allergy. And desensitization: there is a serial escalating doses to create temporary tolerance for necessary meditation, platinum-based chemotherapy, or penicillin. There is a difference of allergic rhinitis and urticaria, the thing which we already discussed. So we skip. Now there is a mast cell in the tissue is the canvas. The first one, the mucosal involvement, there is allergic rhinitis, local irritation. The superficial skin, there is urticaria, superficial vascular leak, the deep skin angioedema, deep tissue swelling, the whole body anaphylaxis, systemic vascular collapse. Now we correlate with the homeopathic concept. What is hypersensitivity in homeopathic point of view, and what is idiosyncrasy in homeopathic. First, we see the hypersensitivity. There is chaotic, energetic, and overreaction and irregular amplitude in allergy. Where there is in idiosyncrasy, there is a unique, precise, highly individual reaction, distinct frequency, and susceptibility. There is a difference between hypersensitivity and idiosyncrasy. First, we see the hypersensitivity or allergy definition, a state of increased abnormal susceptibility of the body to a specific substance, we all know. In idiosyncrasy, there is a peculiar corporeal constitution which, although otherwise healthy, possesses a disposition to be brought into a morbid state by the thing that produces no change in most of others. In hypersensitivity, the nature, the primarily immunological response to external trigger, and the scope, there is general many individual will react to the same trigger with a similar predictable symptom, urticaria from ache, paroxysmal sneezing from dust. In idiosyncrasy, the nature, the highly individualistic personal type of sensitivity, often rooted in chronic miasm. In scope, unique reaction in entirely specific to an individual, fainting from the smell of roses, severe illness from touching to a certain leaves. In allergy, there is a requirement of both antigen and antibody reaction. In idiosyncrasy, if any person can see the cat and then develop the urticaria, then we can put into idiosyncrasy. Now there is a foundation of the vital function. The both hypersensitivity and idiosyncrasy are the morbid expression of the universal biological law, a susceptibility. There is a first we discuss the normal susceptibility, the concept, the fundamental attribute of life, where the hypersensitivity is a quantitative derangement and idiosyncrasy is a qualitative derangement. Normal susceptibility definition, the general quality or capability of the living organism to receive an impression and react to stimuli. In hypersensitivity, the exaggerated reaction to normal stimuli, a state of lower resistance where the organism reacts pathogenically. In idiosyncrasy, peculiar individual oversensitiveness to the one thing or a few specific things that are the harmless to masses. In normal susceptibility, the state, the health and immunity, organism react constructively, digestion, assimilation, and self-protection, while in hypersensitivity, the morbid and disease state. In idiosyncrasy, there is a morbid, constitutionally fluid, a miasmatic. Now we see the architecture of the reaction according to H. Robert. The reaction begins as the expression of the susceptibility is one of the fundamental attributes of life. First, we see there is a stimulation come to a living organism. And the reaction one was the normal and other was a morbid or abnormal. In healthy condition, there is a normal reaction. And in morbid or abnormal, there is an increase when abnormal susceptibility and cause the disease, or if decrease, the abnormal susceptibility and disease condition can occur. Now, the balance of the reactivity. Health is not merely the absence of symptoms, but the maintenance of the perfect physiological balance and normal response to stimuli. Now, there first we see in center, there is a normal susceptibility, represent the health. The organism exhibits normal response to a given stimuli. Or where there is a decreased susceptibility or hyposusceptibility, a state of sluggishness, loss of vital defense, and non-assimilation. Or in case of increased susceptibility, there is exaggerated response, inflammation, fever, or acute sensitivity. The organism as a vacuum, one of the main catches the scarlet fever from another main, but catches is because he is vis minor to the disease. He is a vacuum for its pressure. The cause why he come was him long before the infected appearance. First one, the individual A is healthy. His strength passes it by, has no concern of this. Here we can see in the graph or the diagram or image. Or in individual B, those who are susceptible to the disease, cause why his come was in him and long before the infector appear. Hypersensitivity, the allergic state, altered exaggerated reaction initiated by the antigen or allergen. And there is a trigger factor like egg and have the hypersusceptibility. The reaction was urticaria or use. In trigger factor dust, there is hypersusceptibility. The reaction was the paroxysmal sneezing and coryza. The key takeaway, while susceptibility is abnormal, the type of reaction is common among those affected in immunological response, not necessary constitutional peculiarity. There is a idiosyncrasy and examples are given. The trigger the smell rose and have complaint of syncope. And trigger factor the muscle crave have complaint of a dangerous morbid state of normal consumption. And last one, the so much leaves. Abnormal sensitivity simply from touch. Now the fish analogy distinguishes the response. The allergy of the fish. First Rama, they develop urticaria. Second one was Sita, was that can develop the breathlessness from fish. And the third one was Shyam, they develop diarrhea from fish. Now the origin of the idiosyncrasy. Idiosyncrasy are not accidental, they are born to excess defect and miasmatic inheritance. The acute idiosyncrasy have fewer if for the fault sensitive to rustox. Previously abuse of drug producing anaphylaxis or a suppression of mental and physical morbid condition. Also, Dr. Shetty can say the SORA is the bottom of all three troubles. There is a fundamental cause was the SORA or also tuberculomyces. The clinical value of the idiosyncratic. According to HR, would also say the idiosyncratic are the good provokant for the drugs for which they are idiosyncratic. The danger of the forcible regulation destroying reactivity is destroying the physical basis of his life. Was the endotoxic wall and the loss of small reaction. When the serum injection destroy bacteria but release the endotoxin causing a active degranulation resulting sterile death. Bacteria gone but the patient dies. In second one, the loss of normal reaction. Antiseptic example of tonsillitis destroying a living tissue cell. Phagocyte, prolonged disease and delay automatic formation of antibody. Fever and inflammation are the not evil. They are the sign of a normal reaction and resistance. And suppressing them is elegant with the forcible disintegration. Now there is a treating of the idiosyncrasy, the hypothesis of similimum, and last one there is anti-miasmatic approach for the miasmatic block. There is the law of similimum. Similar potent and remedy is always stronger than the morbid susceptibility. Now we see the healing power of illness, uncovering psycho-emotional root of allergies. First, the allergy is not a biological malfunction. The word allergy comes from the Greek, strange or different, ergos reaction activity. Traditional medicine view in the mistake immune response to harmless particles. We must shift this perspective. An allergy is a highly specific program response to destabilizing event. Here there is a concept was the psycho-emotional view. When there is a psycho-emotional shock, which are the responsible cause for the development of an allergy. They are sudden, the event catch individual completely by surprise, unresolved, isolated, or dramatic. Then the formation of inseparable due. At the exact moment of the shock, the immune system categorizes external environment as dangerous. It releases the acute dramatic event, whether a harmless element was present at the time. To survive emotional pain, unconsciousness, bury memory, living. Only physical abuse as proxy. Here we can see there is emotional shock at the level of unconsciousness or descent into a wind. Descent into which are the cause for the development of a hypersensitivity or allergy. There is a two stage of sensitization. The first one was silent phase. The psychoshock occur. The allergen is present. The immune system is silently analyzed and the manufactures specific antibody. The allergy is programmed. No physical symptom manifest. And there is a noisy phase. The second contact with allergen occur in later life. Antibody become highly reactive. The allergy crisis exploded. The allergen act as unconscious warming of the origin hidden danger. Here there is a case study of allergy crisis. First, there is the shock. A couple argue at the weekend court and the groom unexpectedly end relationship and leave the bride in front of friend. The bride is eating nuts and the destabilizing a trauma is too painful. The unconsciously bury and the emotional memory abdomen abdomen and replaced with the physical presence of the nut. Years later, eating the nut trigger an allergic and an unconscious move, the emotional into the physical body, masking the original trauma with the annoying physical reaction. You see where to look for the origin. In only very small percentage of allergen originate from the mother's pregnancy or ancestral trauma. And after age of 70, the vast majority of allergic program occur between the age of 7 and our current time. Here there is an example. If the element was water, of allergy from water, there is a history of mother drowning, separation, and maternal role. As example, allergy from sun and fire, and the father. Look for the absence of father. If allergy from metal, there is a imposed contact or separation or stabbing trauma. If allergy from alcohol, there is a look for continued fight or divorce. If allergy from bread, there is a look for the lack of the family atmosphere. I have been kicked out. If allergy from food, the trauma occur directly during the meal. Or other examples are there. We didn't go to the detail. The investigation and interrogation, the timeline. Before the allergy can be healed, we must systematically trace the physical symptom back to the origin of the psycho-emotional shock. Ask this 4 golden questions when the allergy flare up. Since when? Pinpoint the exact age or year the allergen begin. The prior window before having a very first outbreak when I was contact with the allergen. The geography, and the last one, the symbol. The unconscious blueprint, the healing protocol, the path out to unconsciousness. First was the investigate, to find all possible historical detail of the dramatic emotional experience, locate the precise connection between the silent phase and the first crisis. Second one, the relive. Face the situation in the time and space. Re-experience the event as if it were happening right now to locate the buried emotional. Third one, the expression. The release the resenting the internalized emotional pain that has keep located into unconscious silent that event. And the last one, resources. When the find the conscious departs from the original position, achieve emotional change to uterate the trauma from the allergen. Now there is a therapeutic foundation of protocol systemic susceptibility. First, there is a tuberculosis. Firstly, most indicated, given 2 doses every week. Improve, achieve, yes, continue monitoring. If no, the transition to sulfur 200 given 1 dose. Exceptional protocol if sulfur phase help to only partially, especially for whatever allergy causing eczema. Utilizing soranum as a chronic of a tuberculin. Response to sulfur, no response, increase the potency to 1N. Now there is a single remedy for the botanical and produce trigger. Strawberry, if allergy of strawberry, use the Fragaria. If allergy from celery, the drug was apium grave. If allergy of onion, puja and natrimul. If allergy of wheat, soranum and natrimul. Now there is a system express matrix cutaneous and respiratory. Cutaneous manifestation urticaria focus, urticaria urens, Fragaria vesa, and thyroidinum. If rhinitis hair fever, there is thyroidinum and sulfur. In eczema, the soranum and sulfur and thyroidine. In asthma dyspnea, thyroidine and Fragaria vesca. Here there is a chart. We direct see the drugs. If allergy of strawberry, already discussed, Fragaria, allergy of celery, apium, allergy of oyster, lycopodium, allergy of dust, pothos, allergy of feather, the sulfur. Now, lastly, we discuss the case. There is a case of allergic rhinitis. 36-year-old patient with disappearance, the intelligence, there is a 12th pass. Chief complaint, there is a
Doctor, the
recurrence.
screen is not
Yes,
moving now. The screen is not moving now.
sir, visible.
Your audio is clear, but your video is not clear.
Can I share?
Share. We can see the screen, but it is not the
Okay, now,
exact. I think it may be due to the network.
not visible.
Oh, it is not coming. You can do one thing. You can say even.
Sir, I can explain case, sir.
Yes, you can explain without screen sharing. That's good.
Yes,
You may open your video first.
Chief complaint, there is a recurrent sneezing, profuse watery nasal discharge, 2 mark. And duration of illness is 5 years. The onset was gradually, duration since 5 years, and progress was slow. And there is a modality, aggravation from warm room, and element trigger factor was the dust, and emulsion from open air. There is a general modality, the patient was thirstless. Here in mental symptom, there is a emotional sensitiveness I keenly marked, and patient has a mild and gentle during the case taking. The patient was too much sensitive about her family or around surrounding others. And the other one symptom, keynote symptom, or I didn't find in any others people, there is a tendency to weep during the coryza, and the patient was cannot bear music during the complaint. Then now further we go. Vital sign, all are the normal: pulse, temperature, blood pressure, respiratory rate. Any other specific pathology is there. Patient already diagnosed case of allergic rhinitis. The IgE level patient was 2080.5 IU by ml. In evaluation of symptom or analysis, I take the symptom: recurrent sneezing, physical particular characteristic, profuse watery discharge, and exposure to dust, trigger factor, open air, emulsion, warm room, aggravation. Patient was thirstless, physical general. In mental picture, emotional sensitive, tendency to weep during coryza, and cannot bear music. There's 3 mental symptoms I have taken. In totality, there is emotional sensitive, tendency to weep during coryza, cannot bear music, thirstlessness, and then my trigger modalities: emulsion, open air, aggravation, warm room, and profuse watery discharge, recurrent sneezing, and a trigger factor was exposure to dust. There is a dominant miasm in this case due to presenting symptom. There is a sora miasm which can cover the most of the symptom. After repetization, I find the 5 main remedies: pulsatilla, Allium cepa, Nux omega, Merxol, Aconite. Pulsatilla can cover the 10 symptom, and Allium cepa was 9, but marking in Allium cepa was 20. But I prescribe the pulsatilla because it can cover the general symptom as well as the mental symptom. And when the patient come, there is a present of episode of allergic rhinitis. That's why I prescribe the pulsatilla 30 BD for 3 days, and also advise for avoid exposure to dust and use mask when going outside. In follow-up, after 3 days, I prescribe only for 3 days, and better sneezing, watery discharge was decreased, and there is no complaint. That's why I prescribe SL for 15 days. In second follow-up, reappearance of the tendency decreased to 40%, and so again I prescribe pulsatilla, and further I increase my potency 200 single dose, and SEC for 15 days. And when after that for 15 days, patient come, there is no any complaint. So that's why I prescribe the SEC leg for 15 days. And then after 15 days, patient come with sneezing and with severe nasal discharge, and complaint was increased, but the tendency of reappearance was decreased. That's why that time I prescribed the pulsatilla 1 m single dose and SEC leg for 1 month. After that time, patient come to me for 3 times, but I doesn't repeat any medicine. Patient was on the SEC leg. Here the IgE level before the treatment there is a 280, and after IgE, as after the treatment, the IgE level was 158.80. IgE didn't go normal, but it is nearly equal to normal. The normal level was below 150, and after the treatment, patient IgE was 158. And here I also use the one scale to know the improvement. There is a scale was Japanese Rhino Conjunctivitis Quality of Life Questionnaires. In that scale, there is a 6 symptom of rhinitis like runny nose, sneezing, blockage of nose, itchy eye, and watery eyes, and other 70 questions which are related to the quality of life. There is a point of daily life, point of outdoor, a point of social, point of sleep, and the psycho life. And the score was also decreased. Before the treatment, the score was 29, and after the treatment, the score was 7. This is the case of allergic rhinitis. And, that's it, sir. And thank you all of you for listening to me, and also thank you the IFPH for providing the platform. If anybody has any question.
Thank you very much, Dr. Abhishek, for your throughout provoking presentation. Your systemic explanation, clinical reasoning, and practical insights have certainly enriched our understanding of hypersensitivity reaction from a homeopathic perspective. I am sure today's session has been beneficial for all. Now, we're looking forward for a question and answer session.
Yes, Dr. Rana,
Yes, sir.
it's really a very good session. And being a junior doctor, you are really placed the allergy conditions in a better way. Your slides were exemplary, brilliant one. And this kind of presentations really will take everyone to homeopathy, because people are not aware that homeopathic doctors are studying all these things and they know what is what. But things are entirely different now. We have what we are studying in our colleges are exactly what this we are studying in our medical field also. But the only difference here is that our medicine and our treatment protocols are entirely different from what the allopathic fraternity. And in this case, the typical case of Busatla, and as our theories proved here that the single medicine works in a better way if you select it with totality. And that's the reason why you got the case. Hope you can win the heart of many patients in the future once you complete your course and you start practicing. Yes, homeopathy is the medicine for the next millennium. So you can really rock into the next phase with good practice. That's
Thank
what
you, sir.
is this Ramparishar sir is there. We can invite Dr. Cannon to say vote of thanks to the session. Dr. Cannon, you can say vote of thanks to the session. Please unmute yourself. Yes. Please unmute. No. Then Dr. Vani, can you say vote of thanks to the session? So, yes, Dr. Binoy. And Dr. Binoy, are you there?
Yes.
Yes, Dr. Abhishek, it was a very nice session, and you have covered all the aspects of allergies and hypersensitivity, and it's one of the common um, issues or common ailments many of Indian and uh, other country the common people face, and you addressed it in detail. And it's a really helpful session for practitioners and non-practitioners, students, and it will allow us to learn more. And homeopathy has is the right way to address it. And thank you very much from an IFPH standpoint and all the participants. And we hope you will come back with the similar sessions and enrich us with the more detailed thoughts and your ideas. Thank you very much once again. Thank you.
Yes,
Thank you, sir.
tomorrow we will have a session from Dr. Namra Trivedi and she is the Assistant Professor, Department of Anatomy, LR Shah Homeopathic Medical College. And she will be talking about migraine and integrated homeopathic approach. Over to Dr. Ringal to conclude the session.
Yes, sir. As we conclude today's webinar, I sincerely thank our respected speaker, Dr. Abhishek Rana, for sharing his valuable knowledge and clinical experience. My heartfelt gratitude to the respected founders and organizers team of IFPH for continuously conducting this remarkable, uninterrupted academic webinar series. Finally, I thank every participant for joining us and making today's session interactive and successful. Stay connected with IFPH, keep learning, and continue spreading the science and art of homeopathy. Thank you.
Yes, thank you, Dr. Ringal. It's over to Dr. P. Shaila to moderate the Malayalam session.